Okay, so you know who I am and what this is about. I have no conflicts of interest, but I do have chronic pain. So Josh and Tommy interviewed me a few months ago, and they asked me about anti-nerve growth factor monoclonal antibodies. And I didn't know a lot about it then, but I did some research on it and thought I'd just mention it at the start of this conference. And I'll pass around some things that come out of pain journals, you know, the advertising for anti-nerve growth factors, which is the latest in monoclonal antibodies. It turns out that the monoclonal antibody industry is now exceeding statins. It's over $75 billion a year. And they've been targeting migraines, osteoarthritis, more recently with FDA approval. Originally, it was for drugs like Humira for rheumatoid arthritis and autoimmune diseases. So osteoarthritis, 17 million people in the US, low back pain, 38 million in the US. What happens with osteoarthritis in terms of chronic pain is a proliferation of nociceptors and sympathetic fibers. And this happens with almost any form of chronic pain. There's a growth, a neuroplasticity in the central nervous system that usually starts at the dorsal root ganglion and works its way up centrally, but also can occur peripherally. And it's associated with an overexpression of nerve growth factor. And in experimental models, injection of nerve growth factor can cause allodynia, which is an abnormal, painful response to non-painful stimuli, hyperalgesia, which is an excessive response to nociceptive input, and muscle pain. A nerve growth factor stimulates nerve growths, obviously, neuronal survival, and sensitization. And my slides just disappeared. And there's a series of biochemical and physiologic responses that result in increased transcription of substance P, BDNF, and other things that increase pain perception, sensitivity, and transmission. So the more recent monoclonal antibodies that are used for treatment of pain associated with osteoarthritis and chronic low back pain are these two, tanezumab and fastinumab. They both inhibit NGF, but they don't bind other neurotrophins. Okay, so these are some references that I'm going to use to follow. So where did these monoclonal antibodies come from? 2006, some early studies, halted in 2010 by the FDA. Some patients with osteoarthritis ironically developed osteonecrosis. There were a few cases of cartilage loss increasing, and there was autonomic nervous system toxicity in animals. So the FDA shut them down. They restarted trials in 2015 with altered protocols, more frequent x-rays, tracking for adverse events, dose limits, enrollment restrictions, monitoring, et cetera, blah, blah. FDA fast-tracked, okay, FDA's fast-tracking all these toxic drugs now. So this is the ground-shaking, earth-altering results. Okay, the WOMAC pain score is a scale from 0 to 20, WOMAC physical function impairment, a scale from 0 to 68. So placebo versus drug, not very impressive, okay? Statistically significant to 0.001, but really on a scale from 0 to 20, 1 point stronger than placebo. And for physical function, 1 point on a scale from 0 to 68, better than placebo. And if you go onto Medscape and listen to this presentation by these researchers, they say this is amazing. I'll quote them directly. But here's for chronic low back pain, the same sort of deal. Okay, compared to naproxen, 500 milligrams twice per day. Change in low back pain. Well, naproxen was minus 1.66. Placebo was minus 1.25. 5, 10, 20 milligram doses of the monoclonal antibody. You can see there's not much difference. It's statistically significant down to 0.001, but really what is earth-shattering about this? But these guys describe this as more effective for osteoarthritis and low back pain than naproxen, effective for those. And here are some of the adverse events, and I don't have the statistics on these, but extremity pain. You're treating pain and they get extremity pain. You're treating pain, they get headaches and arthralgias and joints swelling. And hyperesthesia, which is their back pain's better. Okay, so now these were just slightly more than placebo. So my take was, really? You've got to be kidding me. 75 billion, enough said, next topic. Okay, so we don't have the lights, but I think I passed some of these things around. But this is the advertising that's going around in the pain journals with pretty pictures. We can turn on the lights and look at that later. Okay, so now I'm going to talk about how I spend my day. And this basically is how I spend my day. But when I try to do something for a patient, okay, insurance restrictions. I'm sorry, Mr. Jones, but your HMO does not pay for enemas. I'm going to have to slap the shit out of you. Okay, so this is an actual case I had many years ago, before insurance limits on blocks, before gabapentin and pregabalin, which are useful in reducing neuropathic pain, 50% in 1 out of 6 patients. The number needed to treat for all of these drugs to treat neuropathic pain is 1 out of 6 or 1 out of 7 to get 50% reduction. Okay, so when you hit a home run, it's great. The patient loves it, but you got to go through 6 patients before you hit a home run. Okay, so this was a 58-year-old ultra-marathon runner. I had never met an ultra-marathon runner, and this was about 15, 20 years ago. He fell, fractured his wrist, was casted by a friend of mine. 6 weeks later, when they took off the cast, he had CRPS type 1, which is previously called RSD, complex regional pain syndrome. Presentation clinically is usually allodynia, vasomotor, pseudomotor symptoms. Most people don't know what that is. Allodynia is a painful response to non-painful stimuli. This guy came in cuddling his arm. Even a breeze on his arm was painful. He couldn't wear clothing on his arm. To touch his skin was exquisitely painful. He would scream if you shook his hand. His hand and arm were swollen. They were red and warm, and it changed from that to blue and cold. This guy was completely disabled, and 6 weeks before, he was running ultramarathons. So I did a series of 17 sympathetic nerve blocks over about 6 weeks combined with physical therapy. Today, I couldn't do this. The insurance companies limit you to 3 at a time. You've got to get authorization, which can take several weeks. Meanwhile, the patient is suffering, and the quicker you intervene with this problem, the better the prognosis. Oftentimes, I get patients that have had this diagnosis for 1.5 years, 2 years, and that's too late because neuroplasticity, they already have permanent changes in their central nervous system. And it wasn't until the late 1990s that the mechanism of allodynia was described in animal studies, where they lesion a nerve, and then they'd sacrifice the animal and look at the spinal cord. And it turned out that there was nerve growth from lamina 1 to lamina 3 in the spinal cord. Lamina 3 has to do with sensory input for non-painful stimuli, usually pressure, light touch, feeling, okay? Lamina 1 was the typical pain pathway. So there were connections between those 2 lamina in the spinal cord. This is the first time that allodynia had a pathophysiologic explanation. And it turns out in autopsy studies of humans, the same thing is presented. So all these patients that have had these neuropathic pain problems, particularly CRPS, oftentimes they were told they were crazy, just like fibromyalgia patients. But now there was suddenly an explanation. How is it that just breathing on somebody's skin could cause such horrible pain? It's because of neuroplasticity. Okay, so this guy went back to work and he was flinging around 50-pound boxes of paper, and he was in remission many years later when I saw him, but I haven't seen him for several years. But he's back to running ultramarathons. I mean, a profound change in this guy's life by doing 17 nerve blocks combined with physical therapy. So before I talk about putting needles in people's bodies, everybody gets the stress reduction workbook that comes to see me if they can afford to buy it. But these are all the recommendations: time-restricted eating, ancestral diet, sunshine, exercise in a green space. I explain the importance of family connections. I give them specific rehab exercises. I talk about sleep hygiene, blue light in the evening, yoga and Pilates. I have handouts, supplements occasionally when I think it's indicated and they can afford it, websites, and a list of books, including Josh's book and several others. Okay, so I'm able to do this. I spend an hour with every initial consult and 30 minutes follow-up visits, only because I spend 2 or 3 mornings a week doing nerve blocks, which pay for covering the overhead of the clinic. If I didn't do that, I could not spend time with patients talking. Okay, anatomy of the spinal cord, AP and lateral views, facet joints, discs, vertebral bodies. We don't have pointers, do we? So anyway, I deal a lot with pain generated from the spine, cervical, lumbar, thoracic. So these are pretty pictures. These are the nerve roots we talk about for diagnostic purposes when we're looking for where a lesion might be. On the right side, you'll see where nerve roots leave the spine, going through foramen, or that are the openings laterally for people that haven't taken anatomy. And that's where nerves get squeezed, either centrally or laterally. And spinal stenosis is a very common problem in chronic pain as we get older, especially, but particularly in people that were aggressive athletes like I was when I was younger. And I have everything: osteoarthritis, spinal stenosis, facet degeneration, degenerative disc disease. If you looked at my MRI scan, you'd think I'd be bent over, but I'm not. Okay, so you've got facet joints and you've got the disc interacting, okay, and problems with either of those two entities can cause stenosis. You can have disc herniation or just disc protrusions. You can have hypertrophy of the facet joints. And of course, as with any osteoarthritic condition, you get cartilage destruction, synovial reaction, osteophyte formation. So, so here we go. Black arrows on the left show the nerve roots coming out through the foramen. On the right, you can see a disc protrusion impinging on a nerve root. Oftentimes, it's just a disc. Usually with osteoarthritis, there's a combination of disc protrusions, facet hypertrophy, ligamentum flavum thickening. Ligamentum flavum is the major ligament running up and down the posterior aspect of the spinal canal. Spondylolysis, okay, the famous Scotty dog. Can you see the Scotty dog there? Mm-hmm. Okay, the eye of the Scotty dog is where we do nerve blocks to numb up the facet joints diagnostically. But with spondylolysis, what happens is you're either born or traumatically, that bone separates. And so you can see this on oblique x-rays. Sometimes you can see it, although it's often missed and you have to go back and look for it. But I've had many patients with this problem, and they're probably congenital most of the time. But it leads to instability in the complex of vertebrae and facets. And so there's a shifting of the vertebral bodies, one on the other, anteriorly or posteriorly, and that creates an unstable situation. This is one of the only situations where spinal fusion has been described as being reasonably effective for improving outcome. Discogenic pain, where pain is believed to come from a disc. Mixed results on spinal fusion. The data is usually a drop in pain scores on average of 2 to 2.5 on a scale from 1 to 10 with spinal fusion for discogenic pain, which doesn't sound great. It's just a little bit better than naproxen. But when you, again, that's an average. You can get some patients with 6-point drop in pain scores for a long time. But once you fuse the spine, the problem is that the adjacent joints are taking all the load, and within 5 years on average, they're really arthritic. So here's a picture. This is taken from an old textbook. This is pretty much what my spine looks like. You can see degeneration of the discs. You lose the disc space height, and that puts stress on the facet joints. Obviously, if the facet joints are lined up with a certain height of disc, if you remove that disc height, those joints are going to be terribly stressed mechanically, and they'll get osteoarthritic as well. Then there's ankylosing spondylitis, which has genetic predisposition and might be related to what bacteria? Klebsiella, right. Okay.
Said the non-doctor.
Okay. Okay, lumbar annular tears. What a lot of people don't appreciate, most physicians don't appreciate is you can get sciatica type symptoms, lumbar radicular pain, without a herniated disc, without spinal stenosis. If you get the outer wall of the disc is called the annulus. It's comprised of circular fibers like a steel belted tire, okay? And before you get a herniated disc, you have to get tears in the outer wall of the annulus. And you don't need a disc herniation to get sciatica. These fibers, when they get teared, produce a strong inflammatory response. And if you can imagine a nerve root passing by a tear, there are inflammatory chemokines and cytokines that get released and locally. And so you can develop a sciatica symptom with a normal looking MRI scan because annular tears are only seen on 1 out of 3 MRI scans. And all you see is a bright spot on what's called the T2 weighted image. So there's T1 and T2 weighting in an MRI scan. It has to do with which way the magnet's going. So if the magnet's spinning in one direction, it's T2. Okay, so on a T2 weighted image, there's a bright spot when there's a posterior annular tear or scar in the wall of the disc. But that only appears in 1 out of 3 annular tears. How do we know that? Because in the old days, we did discograms and injected dye into the disc. I did many of those procedures at the request of spine surgeons. And you would see dye leaking out of the disc through the wall of the disc into the epidural space, okay? And the MRI was normal, okay? And these patients were diagnosed with chronic low back pain. We can't find anything wrong. And you put a needle in the disc and inject dye, and there's the annular tear. The problem is that you can find an annular tear and pressurize the disc 50 psi, and some of those people don't feel pain with pressurization of that disc. So what used to be considered a positive discogram was you pressurize the disc and you're measuring the disc pressures through your syringe, through a transducer. And as you increase the pressure, you may or may not see the tear. If you see a tear, then you ask the patient who's awake, excruciating pain sometimes, is this your typical pain or not? I'm not feeling pain, but you go to the next disc and they've got a tear. Oh, that's my pain. And this was the basis for sending patients to surgery. I should say that the surgeon sent the patient to us to do the discogram, and we reported to them. And then oftentimes, you would have a clearer picture with a post-discogram CT scan where the dye would be in the epidural space and you'd see it clearly. Send them right from the operating room to the CT scanner, and you get your diagnosis. Insurance companies don't pay for that anymore. There was controversy about the accuracy diagnostically of discograms. I haven't done one for a couple of years. But the learning point was that you can have a symptomatic disc that looks normal on MRI scan. And when I see somebody with sciatica, which without any nerve compression, the presumptive diagnosis is a posterior annular tear until proven otherwise, and these patients frequently respond to epidural steroid injections. This shows neuroplasticity, granulation tissue, a proliferation of nociceptors. Why this happens, nerve growth factor now, according to the pharmaceutical industry, is one of the targets, but you saw how targeting nerve growth factor really dramatically changes pain, right? Okay, so here's a disc herniation where part of the nucleus squeezes out of a complete tear in the posterior annular wall, squeezes out like toothpaste, and is compressing a nerve root. But you don't need nerve root compression. Remember, all you need is inflammation locally around the nerve root, and you get sciatica. And there were early studies done where patients had their nerve roots ligated in the operating room, woke them up, and the ligation did not cause pain until there was an inflammatory response, okay? So a herniated disc, this shows the typical changes: numbness, weakness, atrophy, reflexes. So you use that old anatomy to try and figure out where they may have nerve root compression. We'll run through these things. Massive herniated disc can cause what's called cauda equina syndrome, loss of control of bowel or bladder, surgical emergency. How often do you see this? Less than once a year in my office. Okay, so the American Society of Interventional Pain Physicians every 5 years or so, publishes evidence-based guidelines. They use Cochrane criteria and Agencies for Healthcare Research and Quality, now it's got another name, inclusion-exclusion criteria for trying to decide what kind of injections are beneficial. Now here, the issue is, what do you use as a positive response? If you expect an injection to produce 6 to 12 months of pain relief, you're going to get very few positive responses. But when patients come in with life-altering pain, they can't move, if you can reduce that pain for 2 or 3 months or even 6 to 8 weeks and get them into physical therapy, get them to change their diet, start to lose weight, improve their sleep because they haven't slept for 3 years, if you can accomplish that for 6 or 8 weeks, that's successful nerve block or injection, okay? So you have to decide what's your endpoint. What do you consider a good clinical outcome? If your criteria is 6 months of pain relief, the studies are going to be negative. If your criteria is 6 to 8 weeks of pain relief with improved daily functional status, with the ability to participate in physical therapy and rehab, then you're going to have a positive outcome. So a lot of the results of studies that the insurance industry uses to say, oh, that's not evidence-based therapy, is because they use ridiculous success criteria. And I'll talk more about the successes in some patients. So So for these different conditions, the evidence for epidural steroid injections, for example, with the different kind of techniques for disc herniation with radiculitis, interlaminar means the needle goes between the posterior spinous processes, between the lamina. Caudal is through the opening down in the tailbone, and pushing the medicine up through the sacral area, and transforaminal means putting the needle through that opening on the side that you saw before, and I think we'll probably have some pictures showing that, or at least some x-rays. So the evidence was rated as good, fair, or limited for all these different techniques, and I use these guidelines depending on the patient's situation to determine what we want to try first. So spinal stenosis, if they've got sciatica, the evidence is much better, but this is just patients presenting with back pain with spinal stenosis. And post-surgery syndrome, where patients come in after they've had laminectomies and or fusions, and they continue to have back pain or radicular pain or both, the evidence is less good because a lot of these patients have neuropathic pain. They've had neuroplasticity, permanent alterations in their central nervous system, usually starting at the dorsal root ganglion and working centrally. And so that's what you're dealing with. But oftentimes you can still get pain relief for a few weeks and get them moving again and starting to be less depressed. And we'll talk about some specific cases with that. So radiofrequency lesioning. So most of the time, it's really not good to lesion nerves. When patients have terminal illness, in the old days, they used to do alcohol spinal injections to completely denervate the lower extremities, or do it higher in the sympathetic chain, which is a little bit safer. We don't do those anymore. But these were patients who were in horrible pain, 4 decades ago, and they'd inject alcohol, okay, into sympathetic ganglia and hope that it didn't spread into nerve roots, and would provide pain relief for several weeks on the patients while they were under hospice care. But we don't do that. Now, radiofrequency lesioning is used in orthopedics. It's used in cardiology. I had my WPW ablated in the early 1990s, and I was cured of SVT, which is an abnormal heart rhythm caused by an abnormal electric circuit in the heart. So I was familiar with radiofrequency when I first learned the technique from the guy who came over from Holland to teach classes in the 90s. And I learned that technique. Most of what I do today, I did not learn at the Stanford Pain Clinic when I was a resident, because they didn't exist back then. All the epidural steroid injections were straight down the middle without any fluoroscopy. I can't imagine doing stuff that way these days. But radiofrequency lesioning, you can target the nerves to the facet joints and lesion them and numb those nerves for 6 to 12 months. And this is life-altering for many patients that have facet pain generation. And we'll have some case presentations for that. So indications for epidural steroid injection, any source of radicular pain, whether it's a tumor, whether it's a herniated disc, whether it's a posterior annular tear. HNP is herniated nucleus pulposus. Foraminal stenosis, lateral recess, and central stenosis, we talked about that. It's just where is the nerve getting squeezed? Centrally, a little bit out to the sides, or all the way out to the sides. Tumor tears, the sooner the better, because you want to prevent the development of a chronic pain, which is due to neuroplasticity, dysfunctional neuroplasticity. And with radicular pain, oh my God, all the insurance companies now require physical therapy for everything before you do an injection. Well, I'm sorry, if somebody has sciatica, physical therapy is only going to make it worse. But you've got to go through this process before you can start doing injections. It's incredible. Okay, so here's a case. So I had this obese retired parole officer. When he came to me, he had been put on over 400 milligrams of morphine per day by a physiatrist. He was on that for years. He had post-polio syndrome. He had atrophy in his left arm, left leg. He had annular tears. He had disc protrusions with lateral recess stenosis. He had facet arthropathy. Interestingly, though, he didn't have sciatica. He just had back pain. Well, initially he had sciatica. I did one epidural injection. The sciatica went away. Never came back. I don't know why. But his low back pain persisted, and it was severe. It didn't respond to NSAIDs, didn't respond to physical therapy. So I did diagnostic facet nerve blocks. I numbed up the facet nerves for a few hours. His pain went away. So we performed the radiofrequency ablation. He had more than 80% pain relief. I tapered him off of all opiate medication. Within a year, he was completely off of opiates. And he has been, since 2013, completely opiate-free. So I've repeated RF ablation procedures, and the literature only goes out 5 years, five repeats, okay, in 3 to 5 years. So we really don't know downstream how long you can keep doing this. And I tell patients, you know, my hope is I'm only going to do this once. You're going to lose 100 pounds. You're going to follow this diet. You're going to walk every day. You're going to get sunshine. You're going to get this meditation workbook. You're going to do, you know, of course, none of them do it. And they keep coming back for the radio frequency, which keeps my clinic open so I can preach about ancestral health principles some more. His wife's a vegetarian. He's from Loma Linda. He's Mexican-American, and he eats tacos and rice and beans. And I tell him, cut the tacos, rice, and beans. And he comes back and says, my wife won't let me. And it's like, finally, I stopped having a conversation with him. Okay. Here's another case study. This poor guy, he's in his 40s. He had 5 cervical spine surgeries, anterior, posterior decompressions, fusions, MRSA, infections, complications, just a mess. And again, he was on over 400 milligrams of oxycodone per day. Oh my God, this poor guy. He was morbidly obese, insulin resistant, in chronic pain, couldn't sleep. He came in, he looked like a zombie. He was sleep deprived for years. And so, but he fortunately wanted to get off of opiates. So he had intact hardware. He had some foraminal stenosis at multiple levels. I prescribed him an Ancestral low-carb diet, recommended the workbook. He's one of the few guys who got the workbook and started using it, which helped. I did occipital nerve blocks for his headaches. They helped a little bit temporarily. We finally got insurance authorization for diagnostic facet blocks, which were positive. We did RF. His pain, again, greater than 80% pain relief, tapered off of opiates. Over a period of 1 year, he's remained off of opiates. This was 2003. I just did a repeat RF ablation on him last summer. Good results. So here we're out, how many years? 14, 15, 16 years now. And he's off of opiates.
How long did that take, Bob?
A year. Yeah. We go slow. Okay, this was, I actually mentioned this on a podcast with Tommy and Josh. This was a retired missionary widow. Incredible story, this lady spent so many years in Africa, I forget what part. She had osteoarthritis everywhere like me. Okay, both shoulders and her knees and her hips. She couldn't sleep on her side because of the shoulder pain. She was sleep deprived, had severe spinal stenosis, facet arthropathy, and she was depressed, anxious. How am I going to live? I can't sleep. I can't lie on my side. So I prescribed an ancestral diet, time-restricted eating, and I did a shoulder joint injection. She came back to see me. She was able to sleep on her side for the first time in a few years after a little bit of steroid in her shoulder joint. She had lost 24 pounds, and she said, I feel this sense of well-being, which that's a great feeling. So I did positive diagnostic facet blocks. We did the RF ablation, relieved most of her neck pain, and I referred her for a total knee arthroplasty, and I haven't heard back from her since. I presume she's had the total knee done or she's dead. I don't know which, but well, you know, a lot of my patients keep coming back, and we do procedures on them, and it's terminal care for a lot of people because I got some very elderly people. The oldest guy I took care of and did injections on were in the early 90s, and he was an alumnus of my college. Okay, this guy keeps coming back once a year or every 9 months for an epidural steroid injection. And this guy had post-laminectomy pain, okay? After a herniated disc and after decompression, he was good for about a year, then he developed epidural adhesions. He's got a little disc protrusion. It's not squeezing on a nerve root, but he's got sciatica. And approximately every 9 months, he gets a flare-up in his sciatica. He comes back, he gets a transforaminal epidural injection. He's good for 6 to 9 months. He's on no pain medications. He's a retired rancher, but that means he just still lives on his ranch and he does less ranching, but he's still a rancher. I've got guys in their 80s who still are riding their horses, but they couldn't walk when they walked into the office. And all they need is an epidural steroid injection. You know, this is anecdotal, but again, I'm told that there's only fair evidence for spinal stenosis. But when you find a patient that responds, you keep doing it as long as they need it. And, you know, an injection every 6 to 12 months with 40 milligrams of triamcinolone is not going to cause diabetes or osteoporosis or that much hormonal disruption. And it's much better than sleep deprivation and chronic pain. So here's a guy, obese vet. We've got a lot of veterans through the Veterans Choice Program now. As a matter of fact, it's about 50% of my patients for the past year and a half, 2 years are vets. And they're from, I've got a few from World War II, some from Korea, a lot from Vietnam, a lot from Desert Storm, and more recently, oh my God, the young guys from Iraq. Oh, it's horrible. They've all got PTSD, traumatic brain injury from IEDs. It's amazing the stuff that I see, and it's horrible the way these guys get shuttled around the VA. But anyway, so here's the typical vet, smoker, obese, pre-diabetic, morbidly obese. He eats out all the time. He lives alone. He's so depressed. I walked in the room, I could smell his BO. His clothes looked like he hadn't changed them for 2 weeks. I took off his socks because he couldn't reach his socks, and they almost stood like cardboard. I mean, this guy was a mess, and he was disheveled, dirty. Okay, I gave him the usual recommendation, but I knew this guy isn't going to change his diet. He doesn't even know how to cook. So I did an epidural injection. He had stenosis at a few levels. He got a little bit of improvement, but he still came back. He was angry because his pain came back in a few weeks. He was still dirty. He smelled, still smoking. Then I injected at a different level, up around L3-4, because he had some stenosis there and he had some thigh pain instead of posterior leg pain. He had both. That's why I started down at L5-S1. But I decided maybe it's the L3-4 lesion. And sure enough, I did an epidural injection, transforaminal at L3-4. He comes back to me a month and a half later, and I could hardly recognize him. He was clean shaven, he didn't smell, he had clean clothes on, and he was smiling. He was no longer angry. And he said he was sleeping, and he started to lose weight. Now, is he going to continue? I don't know. But this guy was transformed. He was depressed. He wasn't sleeping. He looked like a homeless person. And the next time I saw him, he just looked like a regular person. He had shaven, he was wearing clean clothes. I mean, it was a profound change. How long is that going to last? I don't know. But my God, just removing somebody's pain for 6 weeks did that for him. You know, yeah, I was shocked. I've never seen a transformation like that. Okay, so bad posture can cause stenosis. You see these people walking around shopping centers leaning on their shopping cart? That's because with a lot of people with spinal stenosis, as you bend forward, you open up the spinal canal just enough to relieve their pain. Okay, that's how that happens. Okay, poor posture does bad things. The guy on the right is on the standard American diet. The guy on the left is paleo. Okay, spinal stenosis again. The black arrow on the left shows facet arthropathy impinging on the foramina. And down in the right lower corner, those are the facet joints. And you can see the central spinal canal. And the nerve root's got to go right by that facet joint on its way out to your legs or in the neck to the arms. Okay. And up in the right upper corner, you can see it doesn't appear that well up there, but an annular tear in the posterior wall of the disc. Okay. Okay, this just demonstrates, again, you lose disc height and it puts stress on the facet joints. Obviously, those facet joints, if the disc loses disc height, mechanically, those facet joints are taking great mechanical stress, and it'll get arthritic, and then you get into the cycle of worsening facet arthropathy, more loss of disc height, the osteophyte formation down the road. Okay, lumbar facet pain. You know, the teaching was it's back pain. Well, I'm sorry, it can mimic sciatica. I had a good friend of mine, our business lawyer, had sciatica type pain. He had some spinal stenosis. I did an epidural steroid injection. Mediocre response. His back pain was horrible. I did diagnostic facet blocks. I did an RF. His leg pain went away. But if you try to get authorization from an insurance company for diagnostic facet blocks and they've got leg pain, good luck. So you've got to sort of hide it or not mention it when you know you're going down a road of facet joints, because they'll say, no, if you've got sciatica, you can't do facet blocks. Why? Because in all the clinical studies done on diagnostic facet blocks and radiofrequency ablation, they excluded patients with sciatica. Of course they would, because you're designing a study. You don't want to deal with complicated situations. But in the real world, patients have both. They've got low back pain, they've got sciatica. You treat their sciatica, get rid of it. Now they got low back pain. You gotta help that. And many of them respond to facet blocks. But God forbid you should mention in your H&T that they had pain in their leg. Try and get authorization for a facet block. But these are called the secondary, primary, and tertiary pain areas associated with lumbar facet. And in the neck, I've had patients with pain in the arm. It looks like radicular pain. They have stenosis, plus minus response to epidural steroid injections, or their radicular pain seems to go away, but they still have this pain in their shoulder, in between their shoulder blades and their upper arm. You do diagnostic facet blocks, they're positive, you do RF, and they're smiling the next time you see them in the office. So here's sort of the protocol. If the epidural relieves the radicular pain, but they still have axial pain, consider facet blocks. There are patients with normal x-rays, normal MRI scans. So just like in osteoarthritis of the knee, where the pain does not correlate with the degree of osteoarthritis in the joint, same thing applies to facet joints. There have been autopsy studies in patients that have had chronic low back pain with normal MRI scans, and they go in and they do micro dissections of the spine, and they find small cracks in the facet joints or in the posterior annular wall of the disc, or both, okay? So there we go. So normal facet joints on x-ray and MRI scan can be painful, and the pain doesn't correlate with the degree of osteoarthritis. So sources of low back pain, discogenic pain, SI joint pain, soft tissue, and then there can be non-spinal sources like aortic aneurysm, always feel the belly, all these other extrinsic sources of low back pain, pelvic abnormalities, renal problems. You always got to be a little bit of an internist. Osteomyelitis, I've seen 1 or 2 cases over the years presenting with low back pain, but they're miserable. You know, they're usually pretty obvious. They're not subtle. They can hardly move. Multiple myeloma, I've not had any patient walk in where I diagnosed the multiple myeloma, but we got to keep it in mind. Metastatic disease can be osteoblastic or osteoclastic lesions, not always seen on the x-ray. And then there's the 5 cancers that typically metastasize to bone: prostate, breast, kidney, lung, thyroid. I learned that as a 4th-year medical student on the renal rotation. Osteoid osteoma is very rare, but they can be a benign, so-called benign source of pain. We don't need to talk about that much. Lumbar sacralization, okay, I don't know the percentage of people born with this, but it's pretty common, where the transverse process of L5 is connected to the sacrum. And these patients have back pain and oftentimes very difficult to treat. Any asymmetry in the spine can cause stress because of the asymmetry and the mechanical loading in the spine. So SI joint pain, usually over the SI joint, but it can mimic radicular pain or facet pain. Okay, discograms, briefly, here's almost normal appearing discogram in the middle of the slide. There's a little bit of spread of the dye outside the nucleus anteriorly, but interestingly, that usually doesn't cause pain. But the next disc down, there's dye spreading in both directions. They've got annular tears posteriorly, anteriorly. This is what discograms look like from an AP view. Here, it's a left lateral tear at the L5-S1 level. You can see dye leaking out of the disc. And phospholipase A2 is abundant in the disc. When you got a herniated disc or even an annular tear, it can spread out. Once it touches a nerve root, it's like hot pepper. It's very irritating. Schmerl's node, okay, what is a Schmerl's node? It's basically a disc herniation up into the vertebral body through the end plate of the vertebral bone. Okay, they can be painful, but you never know. They're just a sign of arthritic changes in the disc vertebral body interface. What is this? Some more discograms. The dye at the top, that's a normal discogram. In the middle, they've got an anterior tear, and the next one down, an anterior tear. Again, they're usually not very painful because for some reason nociceptors form much more commonly posteriorly, maybe because it's closer to the nerve root, I don't know. This is sort of a nice cartoon. It shows an inflamed nerve root over there on the left with an extruded disc. Here's the corticosteroid, the magic medicine soaking into the nerve root. Oh, and by the way, steroids don't just decrease inflammation, they stabilize the membrane electrophysiologically, so they change the actual threshold for firing of nociceptors. Another reason they may work. Here's a caudal epidural steroid injection. 99% of people have an opening called the sacral hiatus. You can get into that. It used to be used as an approach for women in labor, and it's used extensively in pediatric anesthesia, the caudal approach. There's a needle going through the sacral hiatus, lateral view. Here's a transforaminal injection from a lateral perspective. This angle's coming in. This needle coming in at an oblique angle to the superior anterior aspect of the foramina. That black stuff is omnipaque dye spreading out in the anterior epidural space. And that's just a small amount of dye. You can cover 3 or 4 levels with about a 2 cc injection. Here you can see the spread of dye up 3 interspaces. And the lumbar facet blocks, this is the proper needle placement on the lateral view. Again, here's the facet joints and nerves, if anybody can't remember what that stuff looks like. Lumbar facet blocks, there go the needles on the cervical spine anatomy. This is just to say, same thing up in the neck. You got facet joints, you've got discs, a little bit different sizes, but and much smaller epidural space. Whiplash injuries, graphic description, before the days of headrests. You know, the automobile industry knew about this for a long time, but it took Ralph Nader to get not seatbelts, but headrests. Yeah, yeah. So you can get brain injury, you can get ligamentous tears, you can get disruption of the sympathetic nerve trunk there in the right lower portion of the slide. The sympathetic nerve trunk runs right in front of the transverse processes of the spinal cord. That's the landmark you use to do sympathetic nerve blocks in the neck. And you stretch those and it can get all sorts of strange numbness and tingling and vasomotor, pseudomotor symptoms without complex regional pain syndrome. Just they can get a Hornish sign in their eye, ptosis, meiosis, anhidrosis. Where are we? I think we're done. Okay. Wow. Okay. So I'll pass this around. You can turn on the lights. This is the propaganda from the drug companies on monoclonal antibodies, the new wave in pain medicine.